welcome to another episode of Longevanity. Right now, I am just trying to get ourselves hooked up to some of our other channels here, and once we're live, we'll be able to get going and get started. So I think that that's working now on Instagram. So here we go. Let me just get myself back to my main screen. Perfect. All right. Now I can take these off because I can actually see what I'm doing again. So thank you for joining us here on another episode of Longevanity, where we take a look at sort of the science and the art of trying to live your best life, both inside and out. My name is Amber Bocknek. I'm a physician who has a practice in both cosmetic medicine as well as longevity medicine and wellness. And what we try to do here on our podcast is talk about health active conversations, focusing on topics that promote healthy living, wellness. And at the beginning, I always make it a point to make sure everybody knows that what we talk about here is really meant for educational purposes. Please don't interpret this as your own personal medical advice. These are things that I want to bring to your attention and put on your radar so that you can have thoughtful conversations with your own physician who knows you the best. So again, please don't take what you hear here and directly apply this. These are things to be discussed with your own doctor and always under the advice and guidance of your own physician. So with that said, let's get started. So today I really want to spend a little bit of time talking just about what's going on in the world of hormone-based medicine and longevity medicine in general. And here in my office, I see patients on a daily basis. And it's interesting, we've had a couple of conversations just this last week around access to care around menopause. So today I want to talk a little bit about menopause. And this is actually, somewhat of a new phenomena. It really is. New in the sense of if you take a look at humankind, how long have we had human beings living on this planet? Thousands and thousands and thousands of years. But really, think about the lifespan of human beings. And 200 to 300 years ago, most individuals really didn't live past the age of about 50. So menopause, as we know it today, really is only a phenomena of the last 100 to 200 years or so, give or take the odd outlier out there. So it actually, as a condition, hasn't been around that long because we generally kicked the bucket before we got to this stage. So this is one of the reasons why I think we are all trying to learn, grow, and improve care around menopause care because it's a relatively recent phenomena. So that's the first thing that's kind of surprising. It's really only the last couple hundred years that women have lived long enough to actually have menopause. So food for thought. A second consideration here is just about women in healthcare and the generation of health knowledge in general. This would be particularly as it pertains to doing research studies. So about 20 years ago or so, just that short time frame, prior to that, it was not required that women be included in lots of pharma studies, especially even things for cardiovascular disease, for example, that affects both genders, or insulin, or other health conditions. Women actually were actively excluded from a lot of studies because we are too complicated. Little do they know. But in that sense, they didn't like how we cycled and how we had these hormonal changes. And so having women in a study was really, unless you were doing a women's health topic, was something that was generally avoided because we are unpredictable and we change from time to time. And a lot of pharmaceutical developers were concerned that this might interfere with their ability to get their drug studied, to prove efficacy, to remove variables or unknowns that they would have to explain. So really, until very recently, women weren't even included in the discussion around the development of a lot of our drugs. And what's interesting, again, it's funny, I hear that and I think about that now at this age and stage here in 2025 when we're doing this podcast. But I graduated from medical school in 1996. I was in medical school from 92 to 96. And this was still during that time when they were doing the study. And even as a female medical student, an early doctor, it didn't even social culturally strike me as odd that my gender and half the population were not being routinely included, but we weren't. So more recent requirements now is that for afflictions and conditions that affect both genders, that they really do need to include women. So that's changed, but this is really something that's happened in recent times. So we see a lot of this still impacting how we look at women. Women are not just, other versions of men. We're different in some senses, although we still have all the same organs, same number of chromosomes, et cetera, et cetera. But again, as far as medical history and timing, just to put some context around all of this, we haven't been included for very long. So you have to look at our historical context to better understand where we came from, to know where we're going. So then let's sort of turn a little bit now and focus our attention a bit on menopause thoughts. There still is, unfortunately, quite a bit of controversy around hormones and menopause. So not only has this not been a condition that women live long enough to experience until the last 2 centuries, but even today we still see a lot of lack of knowledge, gaps, holes, etc. When I was in medical school, which again, I guess if I say 92 to 96, it does sound like quite a while ago, but it's really not that long ago, really. We didn't have many lectures specifically on hormone replacement therapy. I'm hard pressed to think in my training if I had more than maybe an hour on it. A lot of my obstetrics and gynecology focused on pathology, focused on pregnancy, conception, contraception, cancers, and the like, and not a whole lot of it focused on women's health issues beyond menopause or perimenopause. And I think that lack of training and focus, it's pervasive throughout the healthcare system. So it's not to criticize my peer group at all whatsoever. We all were raised in that environment, and so it just wasn't part of the vernacular. It's interesting, I was speaking to my husband, who happens to be a veterinarian, and he was telling me about a study that the vets did as far as treatment decision making. And they were looking at what was the single biggest factor in how veterinarians made clinical decisions. And the number one factor was the year they finished their training. So it goes to show you, even though all of our disciplines, veterinary medicine, human medicine alike, we do ongoing education, continuous medical education. But despite the ongoing training, it's almost like we're very much indoctrinated into a way of thinking or an approach based on how we are originally trained. So the old adage, you can't teach an old dog new tricks. So we have to work at it in order to change our thinking. And so it's not to excuse why people encounter difficulty getting up-to-date menopause care. I just want you to understand why you have to work so hard to get the care you need, and why you see a lot of roadblocks that could be frustrating. So doctors didn't get a whole lot of training. The year that you're trained in really does affect your thought process. And one major roadblock in menopause care still today is for anybody who was in medical school, residency, or in practice when the Women's Health Initiative study came out, which was back in 2002, 2003. That's when the big controversy happened. So for me, when I first finished my residency, and this was in 98, we were very pro-hormone, very pro-hormone. I prescribed it widely, and I used all the common hormones that were used in the Women's Health Initiative. And there were some good things that they found in that study. And there were some misinterpretations of the data in that study. It's the misinterpretations that I'm going to talk about in a moment that unfortunately have really almost blocked a whole generation's worth of women, my parents' generation's worth of women, from access to proper hormones and proper menopause care. And so this is this story of throwing the baby out with the bathwater. So what did we learn that was accurate back in early 2000s from this Women's Health Initiative? Well, back then, and myself included, the primary prescribed estrogens were problematic for 2 reasons. Reason number 1 was that we gave them orally, and I'll talk about that second. And reason number two is that we were giving non-human estrogen primarily in North America. Now, Europe was not doing this. So the European studies that came out after the Women's Health Initiative started the whole process of refuting some of the erroneous interpretations that we made here in North America. But it took a while for that information to sort of filter through and figure out what was correct and what wasn't and why. So back in the late 90s and early 2000s, the two most common estrogens that I prescribed, as did many people in North America, was one called CEE, which stands for conjugated equine horse estrogen. So we source this from horse sources, and horses have different estrogens than humans. So that was one of the major brands. And like many providers, it was one that I prescribed as well back then because we didn't know. And the second one was something called Premarin, which also we prescribed very, very widely, including me. So Premarin is like a breakdown of the words pregnant, mare, urine, Premarin. Again, equine, horse. So that was one of the first issues. So humans don't make the same estrogens as horses do. So we were giving estrogen that humans weren't taking. The second problem in all of this is that we were administering estrogen by mouth. That's a problem. Why is that a problem? And so this is a problem. You may hear the term bioidentical or body identical. Bioidentical and body identical avoid the horse issue. It's a human estrogen, exact copy. So your body can't tell the difference between this administered estrogen, and it doesn't matter whether if it's body identical or bioidentical, whether it comes from a pharmaceutical plant, because there are some brands that are, or from a compounding pharmacist that's sourced from yam or soy. Doesn't matter about that part. Your body can't tell. It's exactly the same as what your body makes. Versus synthetic ones that we were taking from horses. The issue was the administration by mouth. So when we take any medication by mouth, as you ingest it, similar to the path that your food goes on, it goes in through your mouth, down through your esophagus, into your stomach, and then it goes into your intestines. As it enters your intestines, just like food, the small particles are then absorbed directly through the wall of the lining of your intestines, and it goes into the blood vessels that nourish that area. It gets collected there. That's where all of that gets collected. And then the next destination down the pipeline from those little blood vessels is actually the liver. And so then the liver starts to break it down and make metabolites of it. When it comes to estrogen, these metabolites, the ones, the extra bonus ones that we didn't want in the first place from the horses that we don't have, as well as ones that would be body identical or bioidentical, all of those metabolites are risky. They can create increased clotting. And so what we saw correctly, and this is actually a correct thing with the Women's Health Initiative, the oral estrogen that was taken increased the clotting risk. So there were warnings that were given around clots and sort of target organs for those clots. So those little clots could travel to the brain and cause strokes, heart attacks, pulmonary embolism, local damage where the clots were. So it's a big deal. You really don't want that. It's not healthy. And so that was correctly identified in the Women's Health Initiative. But really the outcome, what we should have gleaned from that is it was the oral administration. When we give estrogen, body identical, regardless of source, through the skin, and that can be in the way of a patch or cream, a gel, we don't have it going to the liver first. It gets absorbed and taken up in the local tissue and travels to the destination tissue. And by bypassing that, what we call first pass metabolism. And so we're not making those little metabolites. So with the Women's Health Initiative, we correctly identified that giving horse estrogens, or any estrogen for that matter, that doesn't exactly match what our body makes is a bad idea, number one. And giving any estrogen, bioidentical, or one that is coming from a pharmaceutical plant, you need to have the exact copy of what the humans have. So not by mouth, and it needs to be body identical. Those are the key take-home messages that, again, I wish we had gathered correctly, but it's just taken some time to get there. So it's not estrogen itself that is evil. We make it. We have receptors all over our body. We're supposed to have it. It's how we administer it after the fact. And if we mess with nature a little bit, we don't give it in the right way, or we don't give exactly what the body has, we can cause problems. So it's really important that we take these things into consideration. So again, these are important conversations for you to have with your doctor. And especially if you've had any history of blood clots or some of these other things, you want to have a very careful look at your own personal health risks. So again, take this as education. And if you want to have this discussion, now that you have a bit more background behind all of this and want to look at this and explore this further, this is a perfect conversation to have with your primary care provider. So again, I would encourage you and try to load you up with some education to ask those questions. So that's the estrogen story. Now, progesterone has a story as well from the Women's Health Initiative. Let's look, what were we doing? Back in the late 90s and early 2000s, we were using medications called progestins. So this is where the name is really important. Progestin sounds a lot like progesterone. Progestin was used, and still, unfortunately, I think erroneously used in medical literature, as an equivalent word for progesterone when it is not. Let me repeat that. Progestin is not the same as progesterone. So progestin is a synthetic hormone, not body identical, not made in the human body, that has a lot of similar but not identical properties to natural progesterone. So in doing so and administering progestins in the Women's Health Initiative, they recognized, and the Women's Health Initiative primarily had patients on progestins, not progesterone, that those women had an increased risk of breast cancer. So we learned in the Women's Health Initiative that there is definitely an issue with synthetic progestin and increasing risk for breast cancer. So again, breast cancer is multifactorial. If you took a progestin, it does not equal the fact that you're going to get it. It is just one of the exposure risks amongst a litany of risks for cancer. But it's one now that we know about and we have options about. And so we can make choices as to whether we use a synthetic progestin, which is still available today, versus looking at something like a bioidentical or body identical progesterone. Interestingly, again, in the European studies, they were not using these progestins that we were using. So the brand name that I used the most was something called Provera. And again, we gave it very commonly back in those days. And again, I prescribed it as well before we had the knowledge that, again, there was some association here combined with other risk factors. So these are things we've learned since then. So when we start talking about bioidentical hormones, we're using things that, again, match the body. But I find the use of the term progestin very misleading because it sounds a lot like progesterone. And it's not just the lay public that is getting misled. Physicians are as well too, because even in our studies, even in more recent times, still some studies are not teasing out the difference between a progestin product and categorizing and looking at those pools of patients separately from those who are actually on real progesterone. If you took a progestin and you renamed it as gobbledygook, I'm just throwing that out there, you would never equate gobbledygook with progesterone. So just because we made a kind of rhymey similar name, progestin, we kind of have to look at it like it's gobbledygook and can keep it in its own separate category in order to assess it properly for safety. So progesterone is not the same as a progestin. And so the name is very important. Now, progesterone, which is body identical to what we make, comes in many different forms. There are prescription brands that are made by pharmaceutical companies that make body identical progesterone. You absolutely can get that through a pharmacy through prescription. We also have compounding pharmacies who make it from, again, natural sources, but at the end of the day, they're still making body identical progesterone. So the issue in the Women's Health Study was just a single issue here, and that is that it was a progestin, not predominantly progestins that they were looking at, not predominantly progesterone, which is where they conferred that there was an increased risk of breast cancer as a variable. Now, we just had a conversation about oral estrogen versus topical estrogen. So the question sometimes that follows here, if I'm talking to patients, is, well, what about oral progesterone? Is that a problem in light of the conversation of oral estrogen? And the answer to that is no, actually quite the opposite. And again, it's not that there's a different process that's happening with the oral progesterone. Oral progesterone, just like oral estrogen, again, same pathway, mouth, esophagus, stomach, small intestines, and then absorption. As it comes through the wall of the intestine into that bloodstream, it does directly also go to the liver. The liver, just like it does with estrogen, makes metabolites, but it makes a different metabolite out of the progesterone. So the progesterone gets metabolized in such a way that something called GABA is produced. Now, GABA is a naturally occurring thing in human beings as well, too. It's a neurotransmitter that we have that is commonly associated with a sense of calmness, relaxation, improved sleep quality. So one of the chief symptoms that a lot of women have when they get into perimenopause with less progesterone on board and full-on menopause, if not supplemented, is this lack of progesterone and difficulty creating GABA. So sleep goes like right out the window. And with that, again, sometimes comes anxiety and this sense of angst or foreboding or not being able to relax, or the mind always going. So again, progesterone can be very helpful. These receptors are not only in our reproductive organs, they're everywhere. So yeah, they are in your brain. They are in different parts of your body. We have receptors in our bone, in our muscle, all over the place. So it's not just a reproductive issue or a cessation of reproductive function. Hormones are messengers and have jobs all over the place. So this is why there's such a constellation of symptoms when you start to have changes in your hormone levels, when they fluctuate widely, when you start to lose some of that protective, helpful benefit of your progesterone. And progesterone is one of the first hormones to drop off. Even in perimenopause, it starts to become quite reduced because you become irregular. And when you're irregular, you're not ovulating the same way and not at the same quality. And so again, you need that ovulation for that little bed where that little egg came from, which is being released in ovulation. It actually converts into a gland called the corpus luteum, and that's what makes the progesterone. So no ovulation or infrequent ovulation causes an overall reduction in progesterone. So again, this is why symptoms start sometimes well before full menopause. So again, these things can be helpful. Interestingly as well, women make testosterone. Again, women and men, human beings, all have all of these hormones. We just have them in different amounts. And we have receptors for these things everywhere, including testosterone. So testosterone, again, some women were aware that, yeah, women have testosterone too. I think most commonly testosterone is known for its impact on libido and sexual function, but that's not the end of the story. Testosterone is actually far more sweeping. And like I mentioned before in the discussion about estrogen and progesterone, we have testosterone receptors everywhere. You have testosterone receptors, again, in your brain, and you have them in your bone and in your muscle. So testosterone, when you have low testosterone, again, that can contribute to some of the brain fog. Testosterone gives that sort of mental fortitude. So when we are low in testosterone, sometimes we feel more emotionally labile, more fragile, have more difficulty rolling with things, more angst. So again, some of these experiences we have are because we are losing some of these messengers that have roles to do with thought processes and our experience of life in our brain. So it's more than just for libido. It's also for cognition, mental energy, focus, etc. Testosterone has a role in bone. So again, it helps to have a strongly formulated bone in the way we lay it down. Testosterone has a role in muscle development. And again, as we lose it and we lose muscle mass, some women with hormone shifts and loss of some of these hormones have rightfully noted that they can be doing the same exercise and activity, but their muscle mass is reducing and they are gaining weight and their metabolism is not the same. So again, these things help to keep us regulated and in balance. Testosterone is a little bit like the estrogen story as far as how we metabolize it. So similar to estrogen, testosterone can be body identical supplemented, but it should be given not by mouth. The metabolites of testosterone can have some of the similar problematic impacts that the estrogen can have. So testosterone needs to be something that's given in an alternate non-oral route, and there's lots of different ways to do that. Topically with creams and gels, some people inject, other people use pellets. There's all kinds of different ways. Intravaginally, creams, like there's a litany of them, as long as it's just simply not by mouth. And then lastly, the last hormone, just to touch on a little bit, which again, men and women have, is something called DHEA. And so DHEA has a number of roles. Some people might have heard of it as like a weak androgen or like a weak masculine. I use male hormone loosely because, again, both genders have it. It's not just a male hormone. But some people think of it in that category. But DHEA is interesting because it helps with a lot of immune regulation as well as metabolic function. It's really important if you're under a lot of stress to help mitigate some of the impact of having really high cortisol or stress hormones. So again, it's something we want to balance and keep an eye on. So that is the history of menopause, the very short duration that women have been experiencing it relative to the existence of human beings over time. Again, sort of the way a lot of our medical profession was trained was somewhat limited. And then we were pounded with that study, in the early 2000s, but what we've learned about it today. So the big thing is keep advocating for yourself. Seek care, ask questions, know a little bit more about the facts in some of these studies. It may be that you need to ask some of these things very directly, and always do something under the direct advice and supervision of your own primary caregiver. Remember, some of these things, if given in the wrong route or the wrong dose, or if you have a personal health issue, can cause you some harm. And at the end of the day, you want to be healthier after all of this and live your best life. So that's where we're going to wrap for today. Questions are always welcome. I would encourage you to follow us. I have some different ways that you can connect with us. So we do have some information on our website. So if you want to learn a little bit more about some of these things, feel free to scan this little code here, and that will bring you right into our website, and you can take a look at some of the hormone health things we have available for you. Alternatively, if you like our podcast, we're going to try to do this weekly, and I'd love to get some of your questions for topics, so feel free to reach out. But if you enjoy the podcast, I would encourage you to subscribe to us and follow us. We would love to be connected with you and have these available for you to see and view afterwards. So once again, thank you so much for your time this afternoon, and I'm wishing all of you a happy and healthy best life. So until next week, I'm signing off for now, and I'll look forward